This presentation was recorded at the 2015 Gold Coast ANZICS Safety and Quality Conference on Deteriorating Patients.
Thank you, Shane. Over the next 10 to 15 minutes, I'll briefly present to you about one of the studies that I did in collaboration with 4 other intensive care units in Victoria, with an aim to identify the consequences of patients being delayed to be discharged from the intensive care unit. Now, I thought I should keep the acknowledgments at the beginning of my presentations because I was worried that I might finish off without time to acknowledge these people. Firstly, I would like to acknowledge the ANZICS Safety Quality Audit Outcomes Grant for funding this study. And secondly, I would like to acknowledge the CTG and especially Dr. David Pilcher and Dr. Andrew Davis for reviewing the study and refining the study protocol. I would also like to thank the medical staff at the participating intensive care units in Victoria and the nursing staff as well. Without their help, I don't think we would have done this study. Now, my other acknowledgements go to the ANZICS Safety and Quality Organizing Committee for providing me with this opportunity. And I would also like to thank them for making my intensive care as the focus or the focus point of this logo. Now, it's a beautiful intensive care unit. It's on Mornington Peninsula, and it was operational only for the last 2.5 years or so. Nevertheless, we have been contributing data to the ANZICS APD from the time of inception, and we take safety and quality at a very high level. Moving on with my talk. Now, why did I do this study? Rather than introducing this with literature, I want to introduce this study with an experience that I had when I started to enter the training of intensive care medicine. I started my training way back, about maybe 10 years back in the United Kingdom, and I started it in one of the cardiothoracic intensive care units as a HMO or a junior registrar. Now, my senior registrar, I don't know whether he was happy with me or not happy with me. Sometimes he used to praise me, sometimes he used to push me down big time. And one day he was a bit upset and he said, look, you are not doing a good job. As soon as you enter the unit, you should see the patients. Make sure that they are good, and from the time you see the patient, you should be planning their discharge from the intensive care unit. And he said that should be your only task or your only goal. Whenever a patient enters the unit, you got to see that what you can do to get this patient out of the unit. It sort of influenced me, and from then on I moved to Australia, where intensive care training is far more advanced than United Kingdom. I've gone through the TACO, Bala's book, and with Shane, and I passed my exam, learning all the equations and acid-base balances. I've started my consultant job about 5 years back, and when I was starting to take over my role, the only thing that I remembered when I was about to start my rounds was what my senior registrar told me when I was about to start my training, that I should get these patients out of my intensive care unit, and I started my ward round with that in mind. So I did my rounds, and I thought 3 or 4 patients were good to be discharged, so I made plans to be discharged out from the unit. And next day when I came to the unit, I still remember this 80-year-old lady who was good to be discharged the day before. She was talking with me well, she was joking with me. But the next day when I wanted to discharge her, she was no way close to discharge. She was quite delirious. She was trying to jump out of the bed. She was trying to take off her monitoring systems, so on and so forth. So I had to keep her in the intensive care for another 2 or 3 days. And that made me to think, if these patients stay in the intensive care for longer than required, is it good for them or is it bad for them? Obviously, in that patient, it was bad. Then I went and did a bit of literature search. And interestingly or uninterestingly, I did not find anything that sort of said anything about what happens if a patient's discharge is being delayed. Then I thought, why don't I do this study? So I had a bit of influence with with a few of my colleagues. So I got them interested in this project, and we thought, okay, we'll see what are the effects of patients being discharged at a later date than what they were planned, or at the time they were planned. So, although there was no sort of literature in terms of the effects of delay in discharge, the ACHS identifies that patients should be discharged within 6 hours of their planned discharge time. So we thought we'll see how many patients meet this criteria as a clinical indicator. And we did this study over a 3-month period from February 2013 to May 2013. And the intensive care units that participated included Bendigo, Box Hill, Dandenong, Frankston, and Marunda hospitals. The primary outcome of this study was the duration of hospital stay once the patients leave the intensive care unit. Our hypothesis was that if patients get delayed in intensive care, then they would stay in the wards for a longer period of time, and eventually their overall discharge duration may be higher than they were discharged on time. We had a range of secondary outcome measures that included discharge after hours, because we know that people who are discharged after hours have bad outcomes, and incidence of delirium, which I thought would be higher if their discharge is delayed, survival to hospital discharge, incidence of sepsis, and unplanned readmissions within 72 hours to the intensive care unit. We included all patients who were eligible for discharge from the intensive care unit during the study period, and we excluded patients if the discharge was done as part of comfort or palliative care. And we also excluded patients from doing CAM ICU as a way of knowing whether the patient is delirious or not, if the patients had severe dementia or could not communicate, or if they had inability to communicate due to severe hearing loss or brain injury. We defined a delay in discharge as a delay of more than or equal to 6 hours from the planned discharge time. And delirium assessment was done by using CAM intensive care protocol by an independent person who was trained to administer this tool. And we assessed the delirium once every day at a specified period of time. For people who get delirious in between, if that was documented in the history, we included that in the analysis as well. And we defined sepsis as a new infection that has occurred within 48 hours after the ICU discharge of a patient while they are in the ward. Over the study period, over 1,100 patients were discharged from these intensive care units, of which we have included 955 patients. And it's interesting to note that nearly 50% of these patients had a delay in discharge. And the most common reason for this delay in discharge was lack of availability of a ward bed in the hospital. It's a no-brainer, but I think it still proves a point. The median duration of delay was substantial. It was nearly 20.5 hours, which is, I think, is not acceptable. When we looked at the demographics, we found that patients who got a delay in discharge were somewhat older than patients who got discharged with no delay. The other characteristics, such as the sex, type of admission, or whether the patients required ventilation or not, were not substantially different between both the groups. When we looked at the comorbidities, there were no comparable differences between both the groups. But interestingly, we noted that people who got a delay in discharge had a higher SAPS and Apache 3 scores. This was something unexpected when we started this study, because if patients were deemed suitable for discharge, they should be discharged, irrespective of what their admission SAPS or Apache scores were. When we looked at the characteristics to identify any particular characteristic that may precipitate a delay in discharge, we noted that if a patient requires an isolation room, then their discharge was delayed significantly. And when we compared the other outcome measures, obviously the median duration of stay in people who were delayed, who had a delayed discharge was 20.5 hours. most common reason for delay in discharge was lack of ward bed. But interestingly, a small but significant proportion of the people's discharge was delayed to avoid discharge overnight or during non-business hours. The discharge decision was revoked in about 1% of the patients where they got delayed, probably secondary to development of delirium or some other problems. Comparing the other outcome variables, the duration of hospital stay, which was our primary outcome variable measure, did not differ significantly between both the groups. However, non-business hours discharge was substantially higher in people who got a delay in the discharge. While we were planning this study, we thought if the patient stayed in the intensive care unit, then the admitting teams may not be reviewing their patients. But contrary to our belief, it appears that although the patient stayed longer in our intensive care units, the admitting teams were closely following these patients while they were in intensive care, waiting for a ward bed. When we did a post hoc analysis of comparing delirium in patients who got discharged within the 6 hours as compared to those patients who stayed in the intensive care unit for more than 24 hours, we found that the delirium was substantially higher. It was 5 versus 11%, which is quite significant statistically. Since this was an outcome of interest, I thought I would show you the data a bit more in detail. Now, that's the incidence of delirium when a patient was made ready for ward. Although they were not delirious, but when we administered this CAM ICU, about 5% or about 6% of the patients were delirious at the time of discharge decision. Now, when they went to the ward, on first day, the delirium dropped down to about 3%, and it stayed there at the 48-hour mark as well. But when the patient's discharge was delayed, as you can see, at that point in time, their incidence of delirium was about 6%, which is not substantially different. But if they stayed in the intensive care, the first day it went up to 8%, and if they stayed in intensive care for another day, it went up to 11%, and on third day it's 10% as well, which means that this delirium increases the longer the patients stay in the intensive care unit. And the delirium in these patients was somewhat higher in the wards as well. The discharge destination was comparable among both the groups with no significant difference. And to conclude, it appears that a substantial amount of patients, that's nearly 50% of the patients, or 1 in 2 patients when we did this study, had a delay in discharge of more than 6 hours. We have noted a substantial increase in non-business hours discharge if the discharge was delayed, and the incidence of delirium is substantially higher if this delay happens for more than 24 hours. Now, we did not see any outcome differences in terms of mortality and all, because the study was not powered for that, and it's just an incidental finding in this study. I thank you for your attention, and if you have any questions, I'm happy to take them.